All right, welcome everyone. Thank you so much for joining me this World AIDS Day for our webinar series. For those of you who I have not met, I'm Derek Dangerfield. I'm an associate professor at George Washington University in the School of Public Health and the principal investigator of PRIISE, where my work focuses on sexual epidemiology, particularly for racial and sexual minority men. And the mission of PRIZE is to highlight the significance of sexual epidemiology to promote sexual health and prevent disease through excellence in research, teaching, practice, and service. Today is the first of a three-part lecture series hosted by PRIZE Lab. And across these three talks, I'll share the arc of our research program from population science to professional inquiry to personal experience for the past decade. Today, we'll focus on the evolution of the prevention science and those targeted person-centered methods that has shaped my work with particularly Black, gay, bisexual, and other so-called Black sexual minority men. You'll note the title of this talk is also named after the title of my new handbook, published by Springer, which represents over a decade of experience with this population specifically, detailing how we should be supporting this key population in light of the extant literature. And the principles we'll discuss today are not limited to geography, whether we're studying men in Baltimore, Botswana, or Brazil. Community engaged approaches make HIV prevention science more ethical and more effective everywhere. So the rules of engagement for today, I'll share about 25 minutes of material with you, and then we'll move into a question and answer session where I really look forward to hearing from you all. You'll notice that we're in a meeting style because I want this to be as interactive as possible and looking forward to learning with you all. So welcome, everyone. My mentor, Chris Bauer, who actually wrote the forward in the handbook, says follow the epidemic. So we're going to start with the data. Here we see CDC data showing that between 2018 and 2022, HIV diagnosis among Black, gay, and bisexual men have remained stable, meaning no increase, but also no decline. So in prevention terms, that's not necessarily success, that's stagnation. We'll see what more contemporary data look like, but these stable rates really emphasize the ongoing need for us to have targeted, focused interventions, particularly for Black sexual minority men. The HIV prevention field has made tremendous progress, but for Black sexual minority men, the outcomes have not kept pace. Despite decades of research, millions in investment, and dozens of interventions, HIV outcomes for this group have not meaningfully shifted, as we just saw. Along with, along the HIV prevention and treatment cascade, we still see disparities at every step. This is 2021 data from CDC showing that despite higher awareness of HIV status and PrEP, Black sexual minority men were the lowest users of PrEP and had the lowest viral suppression rates. In 2023, 90% of Black, gay, and bisexual men were aware of PrEP, which is a huge progress, but only 38% used it, even with options like the long-acting injectable PrEP that's have become recently available. And it's not that people don't know, it's we're really seeing data showing that it's the systems of trust, patient-clinician communication, and care that have not caught up with the needs of this community. It's really a reminder that knowledge doesn't equal uptake, and the point isn't that we've necessarily failed, it's kind of that we just hit a plateau. So the question really is, how do we break through this? And I argue that this issue is not only moral, it's methodological. This slide summarizes how I frame my entire body of work as a response to the limits of traditional prevention science approaches. We really need prevention that feels relevant, safe, and relational. However, there's a gap. Most prevention models still universalize a concept of risk, treating Black gay men and people in general as a monolith. That not only misses important variation in subgroups, but it can also reinforce stigma. Sarah Calabrese's work showed that we're seeing backlash from targeted prep campaigns as our message seems to pathologize Black queerness. Some folks are actually getting offended by some targeted campaigns. Several studies over the past decade also showed that gay and bisexual men were not necessarily riskier than others, but there's differential vulnerability in the population regarding key factors such as age, geography, and sexual orientation, and even sexual roles. And ignoring these subgroup differences with blanket campaigns has unfortunately created some backlash and stigmatizing the community. So what it seems like we really need a targeted or more relevant unstigmatizing approaches that really reflect community realities instead of abstract categories. The research ethos that really guides my work includes cultural responsiveness, person-centered designs, peer integration, appropriate timing of interventions and studies, and reflective ethics. And all of these things are anchored in the position that prevention should be relevant and it should feel like care. Ultimately, our goal is to shift prevention science away from a narrow focus on risk reduction towards a more life course informed um, uh, approach, which sees people as whole. Now, don't get scared, y'all. When we talk about person-centered analyses and approaches, latent class analysis is a useful technique to quantify the profiles and conditional probabilities of co-occurring behaviors within a group. It's basically data with personality. I've conducted several latent class analyses that consistently show that only a small proportion of population subgroups exhibit the highest risk at HIV or STI risk profiles. For example, we have here an application of LCA for in HPTN 073 using CDC PrEP indicators to see if we could identify uh, subgroups of behavioral sexual risks among Black sexual minority men in that study. And what you're seeing are clear population subgroups showing that Black gay men are not necessarily the same, and they do not all carry the same type of risk. We found three distinct groups here. Class one, we call single with condomless partners. You see, they represent the majority of the sample. And these guys have a 84% chance of being in a relationship or being single, sorry. They have a, almost a 60% chance of using drugs before sex and an 86% chance of condomless, insertive, or receptive anal intercourse. The second group we have is class two. We call it single with multiple partners that comprise 20% of the sample. They had almost 100% chance of being single, a 90% chance of condomless sex, a 96% chance of having at least three male partners, and a 58% chance of substance use before sex. And then class three, we call serodiscordant partners who had a 100% chance of condomless sex, almost a 50% chance of being single, and a 100% chance of reporting any partners who were living with HIV. Now, on the surface, you might think that the serodiscordant partners group was highest risk, but here's the twist. They were actually the most likely to be using PrEP in the sample. So they may not necessarily be the highest risk, also given the U equals U messaging that emphasizes that partners who know their HIV status and are treatment adherent cannot transmit virus even in the presence of condomless sex. So these data align with other studies showing that we may actually be missing those guys who meet the highest need for PrEP. That means and confirms that universal one size fits all interventions aren't just inefficient, they can actually be part of what's stigmatizing and alienating people who don't identify with high risk narratives. And so targeted person-centered approaches aren't just nice and fancy methods, they're absolutely necessary tools to be leveraged in our work with Black sexual minority men because we need more contextual information about sexual relationship context, health beliefs, and subsequent health decision making. So, after years of describing community health issues using these person-centered analyses, I hit a point in my career where I really wanted to intervene on the issues, not just document. And that desire led to a formative NIH-sponsored intervention called Possible that was inspired by the promise of peer-based approaches used globally, from community health worker approaches to the promotorist model. And drew on three theoretical frameworks, including life course theory, which tells us that timing, age, and cumulative experiences shape health beliefs. We also leverage the health belief model, which centers perceived susceptibility, the do I think this could happen to me, and if so, so what questions. And we also applied an innovative framework in public health from the education and psychology discipline called Possible Selves that really orients us to understand how people envision their future selves and if those could be leveraged for behavior change. So together, these frameworks inform the design of Possible, which was a multi-component health communication intervention that combined behavioral self-monitoring with culturally congruent peer change agents. Across 10 publications that emerged from this body of work, we moved toward a single goal to create science of prevention that fits the realities, needs, and concerns of the folks we hope to serve. Because the science only matters if people can see themselves in it. Before Possible was an intervention, it was a set of formative questions. We conducted 12 focus groups in Baltimore to really understand what ideal peer characteristics meant in their terms, not just what we as researchers thought it meant. So across these groups, several things stood out. Most participants reported low perceptions of HIV risk, and that insight really helped shape the entire script that we designed. Because if people don't think something can happen to them, knowledge alone won't change behavior. We also learned that self-monitoring sexual behaviors, things like digital tracking or journaling, was perceived as feasible, but it could also trigger internalized stigma or stereotype threat, the fear that I might actually be what they think I am, and somehow that's bad. So there was a real ethical challenge of how to make reflection empowering rather than shaming. Participants also described what kind of peer they would trust. And they mentioned someone who was aesthetically relatable, including aspects related to their hair, the way they dress, and subjective attractiveness. They mentioned that the person needed to be culturally congruent, specifically Black and gay identified or LGBT identified. Consistent with other studies and including some others that I've led, they reported that folks needed to be genuine and caring, which comes up all the time. And they also said they had to have a history of prep use and willing to discuss those experiences and including side effects that may have emerged so they could ask questions to see if that might be something that they might could handle themselves. Also consistent with other studies, especially in the substance use literature, participants reported someone wanting to engage with a peer who felt like a future self, someone who was aspirational but still relatable. And that comment about the future self really became the conceptual anchor for the intervention. One group explicitly looked at me and said, you're sitting there looking at us like that's my past and I'm their future self. So we don't have to worry about what we're going through. And after those groups came the real plot twist. My team, and Dr. Anderson is in this photo, decided that I should actually serve the intervention as the peer change agent. We actually put this photo in our R1 that was funded last year, but unfortunately terminated due to allegations of DEI framing. Um, at first, I resisted for all the reasons you might think and imagine and can understand. I felt like it really blurred the line between researcher and participant. And I also wanted to maintain as much objectivity for my first intervention as possible, no pun intended. I even asked my chief of staff, Miss Charlene Wiley, if this might be something pragmatically or ethically appropriate, and she also supported our decision as a team, as a lab. And so ultimately, I agreed, not just because it saved us thousands of dollars in human resources, but because I realized that this was exactly what the theory demands and an intervention in this space really demands a prep using principal investigator as a peer, really embodying the intervention rather than just delivering one or leading one. So it really turned out to be one of the most difficult experiences of my career, sharing the vulnerability with participants to facilitate community health in a novel way. And it completely redefined what I thought it meant to do prevention science. I actually documented my 2-year prep journey and role as the peer change agent in an autoethnography published in the International Journal of Environmental Research and Public Health in 2023. And I'm happy to talk more about that and things of that nature in greater detail during our discussion. But here's a visual representation of the possible model. The study involved 2 virtual sessions where I served as the peer change agent using what we called an MI plus approach, motivational interviewing plus selective self-disclosure in the tailored communication. I worked with participants to identify goals, explore their risk perceptions, and encourage their prep use even when they were hesitant. Sometimes I share my own prep experiences and relationship dynamics and health beliefs to make things real, to help move people from awareness to action. Before their month 1 follow-ups, they downloaded the publicly available app called Prep Me, designed by nurse scientist Dr. Jason Farley to self monitor their behaviors over the course of the month, then bring it back for discussion to see if they thought they needed prep in light of what they reported in their diary. And it worked at baseline. Preliminary data showed that perceived risk for HIV significantly improved after the baseline session, and 64% of folks in the study accepted a referral to PrEP, and 45% of those individuals actually scheduled appointments. Participants also reported feeling understood, respected, and cared for in follow-up surveys. And it's really a testament to the relational and emotional experience that's required in engaging this group and designing promising interventions. And this work is not just about recruiting participants. It is about reimagining relationships and roles in research. After documenting our peer-based interactions and process, we ask the next logical question in light of contemporary approaches is, can we digitize relational care? So we took the intervention script and conducted a content analysis of the peer participant interactions and translated it onto the decision aid, an online tool, using the script domains and identifying patterns in participant concerns and responses. The goal here was to see if we could capture the emotional intelligence of a peer interaction in a scalable digital format. What we're really testing is, do we need the person or do we need the language and approach that the person uses, which is an important distinction for the future of prevention science, especially as we move forward to digital, hybrid, and AI assistant health systems. And this tool, which is available for viewing on prizelab.com, represents a significant step toward relevant digitally mediated prevention, one that really maintains empathy, cultural congruence, and agency even outside of a face-to-face interaction. So I'm also proud to share that this work was just published this week in Health Education Research, which is a milestone that closes one chapter of the KO1 award and opens the next. Here are some of the most unexpected and personal outcomes of this body of work. First, what we learned is that culturally congruent interventionists really redefine what expertise looks like. And I know Dr. Dustin Duncan has recently written about this, about how in-group interventionists, authors, teams are not just messengers, they're really translators of prevention into relational care and understanding, really embedding health conversations within trusted networks that already exist. So when somebody says he gets me or he cares, that's not necessarily anecdotal, that's data and intervention. That's relationship operating as an intervention mechanism. Second, care itself functions as a mechanism of change. Through empathetic engagement, we're talking about listening, reflecting, sharing, um, and being vulnerable. We see promising shifts in health beliefs and reduced PrEP barriers. It's not necessarily the message that moves people, it's the manner of care. Third, this work has really deepened my understanding of insider research as an ethical tension. Being both a member of the community and a scientist does expand access and trust, but it also intensifies the emotional and professional labor that's involved in doing this type of work. It requires a constant balancing act between empathy and boundaries, advocacy and analysis. And we've written about, what I call the ethics of inquiry in this work with particularly Black sexual minority men. And finally, there are still some unresolved structural questions that we cannot necessarily answer through intervention alone. For example, can individual or network level care truly overcome key barriers such as structural racism, homophobia, and systemic inequity? So collectively, these are not just theoretical tensions, they are limits of what even the most person-centered science can achieve when society itself is unequal, which is why for me, the next frontier of prevention is not only innovation, it's also accountability. This body of work doesn't just inform my handbook or work with Black sexual minority men in the United States. It reframes how we think about who prevention is for and how it should feel. Together, this body of work informs the foundation of prevention science that really sees Black, gay, and bisexual men not as high risk, but as um, high priority for inclusion, high priority for innovation, and high priority for respect. The truth is, these issues are not unique to the United States. Across the African diaspora, we're talking about everywhere from South Africa to Jamaica to the United Kingdom to Canada and Brazil. We see the same structural conditions reappear related to racism, homophobia, economic exclusion, and distrust of medical systems. Peer and community models have community-driven models remain some of the most effective approaches that we have, but scaling them is not just a matter of translation, it's a matter of adaptation, scripting, and sustaining the infrastructure to continue those interventions. However, across contexts, the triple weight of racism, homophobia, and HIV stigma continues to blunt even our best biomedical advances. And so the hope and the challenge really lies in a transnational collaboration, really building a prevention science that moves not just east to west, but really across the diaspora and learning in both directions. Because we're not experiencing isolated epidemics. We are experiencing interconnected social realities that affect people's lives and health. So where do we go from here? First, we need to prioritize relevance, personalization, and cultural congruence in our intervention designs. Because prevention that doesn't fit people's realities will never reach them. Our science has to feel relevant. It has to, as much as it has to be rigorous, and it has to be grounded in real world context, not just in controlled conditions. Second, we need more Black gay researchers. We need more Black gay clinicians. We need more Black gay practitioners that are leading this work. Representation is not just a checkbox, it is an epistemology. The way people see, interpret, and respond to prevention changes when those people who are most affected are also the ones shaping the agenda, translating findings, and designing interventions. Third, we need updated models of care, not just biomedical care, but really a relational, reflexive practice, the kind that really honors emotion, trust, and a shared humanity as mechanisms of change. And I know clinicians are often well-meaning, but care must evolve from a service model to a science of connection. We also need to integrate life course and socio-ecological frameworks, and this remains essential. We have to account for the role of timing, identity development, context, and cumulative effects of structural inequalities across a lifespan that impacts their health. And finally, we need to fully embrace what it means to have person-centered and socio-ecological methods, approaches that allow us to see heterogeneity, not hide it. If I'll say if this work has taught me anything over the past decade, it's that risk is not a fixed identity. It really is a reflection of opportunities or lack thereof, context, and care. So the next phase of prevention science isn't about just closing gaps and reducing disparities. It is about building systems of belonging and care where science and justice can coexist. And that's the future I'm hoping we can build together. So together, collectively, this really forms the foundation of my handbook and a broader prevention science that sees Black gay men not as high risk, but high priority, as we have discussed. For those of you who want to deeper dive into the frameworks, the data, the stories that I've touched on, I invite you to review this body of work on prizelab.com, where you can also find our handbook. Now, let's talk. I know we've covered a lot from the evolving landscape of HIV prevention to uh, personal dimensions. I'd love to open it up for questions and thoughts and even challenges. That's where, the challenges are where the science begin. Um, thanks so much.